Welcome! It's a learning festival of sorts.
Look at that, it's poo. Really? Is that poop?
Us doctors call it stool. Not this stool, this stool. But it's okay if you call it poop. I'll know what you're talking about.
We need to be scientifically precise. Not stool, feces.
Doo-doo, that's what we call it at home.
Duty!
I prefer number 2. That's more discreet.
Come on now. It's just fecal matter. Tell it like it is.
It's taking a dump.
You mean having a bowel movement? We all do it.
Oh, come on, let's just go ahead and call it.
Hey, hey, hey! We cannot say that.
Spinal cord injury causes motor weakness. Even the bowel is affected.
When I was injured, I'm paralyzed from here on down. I just had to go on and adapt.
It's a confusing, bad time. He lost control of everything. We were overwhelmed.
Without messages from the brain, the bowel runs on its own reflexes.
How do you go potty in time?
My helper is my caregiver. Sometimes I call her my attendant.
That's me. It's my job to help.
At first, I didn't know how to take care of him.
The solution is simple. The products are all here for a complete bowel program.
We transfer the patient from bed to a commode chair, and this offers support for upright bowel care. It also doubles as a shower chair for cleanup right after bowel care.
It's your choice, sitting or lying down. It's a matter of what works best. It's great to have a choice.
If I try to skip my bowel care, it's a complete mess.
One thing I'm definitely sure of, accidents really stink.
If you don't do your bowel care regularly and well, then the stool gets backed up. And then we have to use strong medicines and enemas.
A good bowel program is something you depend upon. It really gives me freedom. We really enjoy getting out regularly.
He's right. He can plan his day. He can plan his life, really. His freedom is the bottom line.
We've had good success. What they teach really works. We're happy.
You got to make it a habit. I do it by the calendar.
Predictability.
Because you don't want to have an accident.
There are about 250,000 people with spinal cord injuries here in the U.S. About half of those people require extra assistance on a daily basis. Without treatment, many of the spinal cord injured patients have no control over bowel function. A team of local researchers, clinicians, and educators created a video that talks about this treatment. Jerry Brown has the story. Jerry?
With me now is Nurse Wendy Miller, a nurse specialist here at the VA Puget Sound Healthcare System, and Dr. Steve Steens, a researcher and specialist in spinal cord injury medicine, who is also living with a spinal cord dysfunction himself. Wendy, Dr. Steens, what was the concern that prompted your group to start working on a video about bowel care?
We found over the years that although persons with spinal cord injury need regular bowel care, they often don't do it for one reason or another.
What is so important about doing bowel care on a regular basis?
Well, the chief advantage of having bowel care on a regular basis is that it gives people with spinal cord injury the ability to predict when and where a bowel movement is going to occur. It's important for anyone's ability to plan for work and social settings. No one wants to have accidents. Scientific studies have shown that people who do bowel care on a regular basis have fewer accidents. They have a higher level of well-being and an improved quality of life.
Studies cited say that a well-designed bowel program can prevent up to 99% of unplanned bowel movements. The literature suggests that bowel care, done on a regular basis, prevents overfilling of the colon, that over the long term can lead to the need for a colostomy.
You've talked about some pretty convincing reasons to be doing some type of bowel program, yet some people don't. Can you tell me more about that?
People with SCI give us many reasons why they don't do bowel care as completely as we recommend.
That's right. Some simply deny that they need a bowel program. Others are concerned about asking for certain aspects of bowel care. Still others are concerned that it might be perceived as something sexual.
Sexual? Isn't this a procedure for good health?
That's right. Most people with spinal cord injury can't even feel the process of bowel care. We find the subject of bowel care embarrasses a lot of people. The communication needed between the person with spinal cord injury and the caregiver just doesn't happen. It's a tough subject, but it's too important to let it slip between the cracks.
National surveys have found again and again that those of us with SCI rate bowel care issues as major life-limiting problems. We want people to know that an effective, well-designed bowel program can give a person with SCI the freedom to decide when and where to have a bowel movement.
Yes. And the ability to plan for work, play, relationships, their future.
Well, thank you, Nurse Miller and Dr. Steens.
Thanks, Jerry. We heard from the medical staff. Now let's hear from people who are actually living with spinal cord injuries in our community.
I used to be pretty shy with my caregivers, and I didn't get everything I needed. I ended up having a lot of accidents, and I lost a lot of caregivers. I found myself not wanting to go anywhere or do anything because I was afraid of having accidents. Since I've been able to be more specific in my bowel care, what my body needs, I've been able to go to school and get a job. I'd have a tough time at work if I didn't do my bowel care on a scheduled basis. And I know that my coworkers would too.
After I had my spinal cord injury, I had no idea when I'd have a bowel movement. Having a bowel program that works gives me great confidence.
Living without a bowel program is like sailing in uncharted waters. My bowel program keeps me sailing on course.
Time out for theory.
This is an apple, and this is you, or actually, your gastrointestinal tract, or bowels. All we're trying to do is show the basic lay of the land. Very soon we'll explain how bowels actually work. It all starts with a bite of this apple.
But first what we have to do is learn the names of the parts of the body. This makes discussing bowel care much easier.
Okay, the apple gets chewed up in your mouth, and it starts its journey through the gastrointestinal tract. Most of us refer to it as the gut, or bowels. The apple is swallowed down the esophagus, goes through the stomach, and then gets digested in the intestine. What's left ends up in the large intestine, also called the colon. It stores the waste products of digestion and takes water out of them to form stool. The colon starts here and moves stool in a clockwise direction. The colon ends up here at the rectum. The last segment ends at the anus.
Hold it! So what does keep the stool in there?
The anal sphincters do. Sphincters are rings of muscle that separate the gut into separate parts, like doors between rooms. The colon has two sphincters, one on the right, one on the left, to constrict and hold the contents in there while water is absorbed and stool is formed. This model is a model of your lower abdomen, as if it were cut in half, just like this. Here at the end of the rectum, there are actually two anal sphincters. They are just below the rectal vault that holds the stool. The first is the internal anal sphincter. It is the muscle inside the anus that runs around the rectum. The internal anal sphincter squeezes gently and automatically to keep the colon closed. The external anal sphincter is just inside the anal opening. It squeezes and relaxes voluntarily. Can you feel yours?
Of course, most people with spinal cord injury can't feel their anal sphincter or stool in their rectum.
The colon is made up of rings of muscle that push stool and strips of muscle that pull stool along. Peristalsis is the coordinated interaction between the muscles in the colon that push stool along. After we eat, peristalsis increases. We call that the gastrocolic reflex. Some people find peristalsis a concept that's difficult to imagine. So, I've got a videotape of a test called a barium enema that shows peristalsis in the colon.
The colon in this X-ray film looks like it's suspended in mid-air. The white stuff is barium lining the colon, so we can see the colon wall move. The movement you see is a peristaltic action of the colon pushing the barium along.
Stool is pushed through the colon with peristaltic action. It's an action much like squeezing a tube of toothpaste.
Once we're on the toilet, we can relax our anal sphincters, bear down, tighten up our abdomen muscles, and let the colon push out the stool.
Time out for a quick reality check. Enough of this books and theory. We'll never remember this medical stuff unless we can apply it to our own lives. Now, pooping is a fact of life. How does it work in the real world? We're going to look at it. Well, sort of.
Hey, brain, stomach here. You were supposed to stop and feed me over an hour ago. I'm really hungry down here.
Stomach, this is brain. Please, keep your acid out of our esophagus. We're really busy. We've got a lot of work to do up here.
Oh, yeah? Well, if you don't take care of me right now, I'm going to have a talk to our circulatory system and I'm going to let it know that we're starving down here. And pretty soon, you're going to feel so weak that you're going to have to feed me.
10-4 to that. Don't get all in an uproar. We'll get something down to you really soon.
Yeah, could you hold all my calls, please? It's time for lunch.
You who up there, Mr. Brain? Guess who? It's Bowel down here, way at the bottom of the food chain, doing what I do best, disposing of refuse.
Stand by on that, Bow. We're pretty busy up here.
You don't get the big picture, Mr. Brain. You should know what bean burritos do down here. I need some attention, and I need it now, or we're all going to be embarrassed, if you catch my drift.
10-4 to that last message, Bow. Brown alert. Brown alert. Let's put it into manual override. All systems. We're initiating emergency procedures. This is not a drill. I repeat, this is not a drill. All systems, we have touchdown.
Okay, let's review what we just saw. Peristalsis pushes stool through the colon and it ends up in the rectum. When the rectum is full, we feel it. It sends a message to our brain that we're full. So what we do is we tighten up our anal sphincters and we hold it in till we can get to the bathroom.
Okay, the play is over. Let's see how that works if you have a spinal cord injury.
Hello up there, brain, can you hear me? It's your bowl down here, way at the bottom of the food chain, doing what I do best, disposing of refuse.
Technology sure makes work easy. I'm sailing into the weekend.
Oh no. Oh no. This is getting serious. The brain better get wind of this. Hello? Hello?
What are those?
I need some attention, and I need it now. I think it's gonna blow.
We are sorry. All lines are out of order. Please try again later.
Attention all systems. We have a definite alert from olfactory. Please initiate visual inspection.
Houston, we have a problem.
Oh no.
Yes, Dr. Grant.
Rose, could you cancel the rest of my afternoon appointments? Tell them that I've had a personal emergency and that I'm really sorry.
This is a model showing the bones of the spinal column and the spinal cord inside. After a spinal cord injury, you're cut off from sensation of the bowel and voluntary control of it. Without a connection to the brain, the bowel runs on its own through reflexes. Let's review the effect of a spinal cord injury on bowel function. First, eating triggers the gastrocolic reflex, which produces an increase in peristalsis. Then, stool is pushed through the colon to the rectum. This is where things differ for people with spinal cord injury. There is reduced or absent sensation of the stool in the rectum, and no signal to get ready for a bowel movement. As stool pushes against the anal sphincters, they may give way, causing an unplanned bowel movement, or involuntary tightness of the external anal sphincter can hold stool in and result in overfilling of the colon. That can cause serious medical problems.
We've got the plans for the plumbing and the valves. Let's find out what to do about it. Time out for a quick review of two basic definitions. Remember, bowel care is just one important element of an entire bowel program, which also includes a diet of fiber-rich foods, exercise, medication, fluids, and scheduled bowel care. Bowel care is a part of a bowel program. It's the actual procedure for triggering and assisting bowel movements on a regular basis. Bowel care, that's what we're going to cover next. Okay, the clock's running. Let's get the steps of the play.
Bowel care is broken down in 8 separate steps. We're going to be reviewing what these steps are, how they're done, and why they're important. Later, we'll be doing a home visit to review these steps more thoroughly. The steps are: first, position the client, thoroughly wash your hands, examine the rectum, apply a stimulant, wait for the stimulant to act, digitally stimulate the rectum, recognize when the bowel is empty, and thoroughly clean up when you're done. The first step is client positioning and setup. The ideal position for bowel care is, of course, the commode chair. If the client can't be on the commode for skin reasons or bathroom inaccessibility, then they should be positioned on the bed with their left side down. The side-lying position with the left side down puts the right colon up, and this will help with emptying. The knees are flexed to stabilize the client. There should be enough space behind the buttocks as to catch a stool, but not so much to make it hard to reach. Items that need to be used should be within easy access. Anything that needs to be opened should be.
Remember, the colon is like a big question mark. It starts on the right, runs up, and down to the left.
You should use an antibacterial soap and, of course, gloves to provide an added barrier to protect both you and your client against stool contamination risks.
The human colon is full of some very nasty bacteria. They're normal there, but if they got out and got into a cut or got into your food, they could make you very sick. The gloves and the antibacterial soap are just precautions for safety.
The third step is the rectal examination. You're going to want to see if there's any stool in the rectum or not. This is the rubber buttocks model that we use for our bowel training. It's in the left sideline position just like a client would be. First, you're going to put on a clean pair of gloves. Then you lubricate your examining finger. When working with a real person, you need to use your hand to push up on the buttocks to get better access to the anal area. Next, you put the fingertip right on the anus and gently push it through the anus as the sphincters relax. You may feel stool in the rectum. If you feel stool, you should gently remove it by hooking your finger around and gently easing it out. Removing stool like this is called manual evacuation.
If you don't take the stool out, when you place the medicine, it could be put into stool. Then the medicine would have no contact with the rectal lining and it wouldn't work. You completely remove the stool, so when you place the medicine, it will distribute along the rectal lining evenly and widely to get the best results.
That brings us to the fourth step, which is a placement of the stimulant medication into the rectum. Stimulant medications are used to start bowel movements and come as either mini enemas or suppositories. It's important that the suppository or enema make complete contact with the rectal lining.
The stimulant medication works by producing a mild irritation of the rectal lining. That triggers peristalsis.
Step 5 is simply to wait for the stimulant to work. It may take anywhere from 5 to 15 minutes for the peristalsis to start. You and your client will have to work out what each of you are going to be doing during this time. You may expect some gas to pass, or some stool may even come out.
During this time, the medication spreads out and stimulates the rectal lining. The time it takes varies depending on the type of medication and the individual.
The sixth step is digital stimulation, or DigStim for short. Digital stimulation is a circular movement of the lubricated finger inside the rectum. As you slide your stimulating finger into the opening of the anus, you feel the firm squeeze of the external sphincter and the firm squeeze along your finger of the internal sphincter. When you do the digital stimulation, you move it in circular motions, and this will relax the sphincters and cause reflex peristalsis. Here's an example. With my finger in the funnel, you can see how my finger maintains contact with the rectal wall all the way around as I move it in a funnel shape. Digital stimulation starts with the insertion of the finger into the rectum and then a circular finger movement. Most people with spinal cord injury need digital stimulation done every 5 to 15 minutes during bowel care to keep peristalsis going.
Digital stimulation increases the strength and frequency of peristalsis. It's an absolutely necessary part of bowel care. Digital stimulation makes bowel care go faster and helps get more complete results.
Step 7 is simply knowing when the bowel movement is over. There are several signs that help you decide. Gas and stool flow has stopped. There may be a tightening and closure of the internal sphincter. You may see a small amount of mucus after the last stool. If there are no stool results after the last 2 digital stimulations, you can be pretty confident the bowel movement is over. Also, the client may have some sensation that it's done and be able to tell you. Our last step is cleanup. First, wipe any remaining stool off the client. The stool and the toilet paper should be flushed down the toilet. Everything else should be put in a plastic bag and thrown out in the trash.
Wow, we sure have heard a lot of theory about bowel care. I think it's just about time for that home visit the nurse told us about earlier. Let me introduce you to Delane.
My name is Delane, and I've got a spinal injury at the 5-6 level. I've been injured for 4 years, and one thing that I've come to realize is that I must pay close attention to my entire bowel program, or I'm the one that suffers the consequences. It's me that has the accidents.
Delane recently had a wound that he thinks could have healed sooner if he had been able to stay off it more. He decided that he and his attendant, Darren, both needed to learn about sideline bowel care. So if there is a next time, he'll be more prepared. We have a visiting nurse, Gary, to help us learn sideline bowel care.
To ensure success as a caregiver, there are some things that need to be understood. First, the client is in charge. Of course, you need to speak with the client on how to do the practical matters, but the client is ultimately the decision maker.
I've been very clear about what I need and why, so Darren is able to do what I need without misunderstanding.
Before we get started, we must prepare. Keep in mind, if the bathroom is accessible and the client is capable, the upright commode chair is a preferable alternative to the sideline technique. However, the sideline technique can be done in almost any situation.
So, how often do you do bowel care?
I do my bowel care every day at the same time between 7:30 and 8:30. I know a couple of guys that do it every other day. In fact, one guy I know that does it every third day. I tried doing it every other day and I had an accident.
Our bodies sure have a way of letting us know when we aren't taking care of it, whether we have a spinal cord injury or not. So what else do you do for your bowel care?
I discovered that drinking hot liquid like coffee or some other beverage helps me with my bowel care.
Ah, you've perfectly described the gastrocolic reflex.
Bowel care sure went faster after he figured that out.
Eating or drinking a hot beverage can trigger this reflex and start peristalsis. That's why it's best to try to schedule your bowel care anywhere between 30 and 90 minutes after you've eaten or had something to drink.
But you have to be careful with what you consume. I used to have a large breakfast, but I started to gain some weight, so now I just have a little coffee and a smaller breakfast later.
I see you have your equipment and supplies already laid out, and that's going to really make things go by a whole lot easier.
Delane finished his coffee a few minutes ago, and this is when we normally do his range of motion and get him up to the commode. But I'm not sure what we're going to do now, though.
Oh, that's easy. You can still keep with his routine. Go ahead and perform range of motion, and then we can roll him on his side instead of putting him up on the commode chair. Delane is positioned with his left side down. His hips and knees are flexed with a pillow under his right leg.
The pillow keeps my knee and ankle bones from rubbing against each other, and that could cause a skin problem.
These waterproof pads are nice to protect the bed. A lot of people use chucks similar to these. I know a few people who are on a tight budget, and they may use plastic bags and paper towels. Others I know use newspapers and toilet paper. But all these methods work just as effectively.
Chucks are nice. I tried to use them overnight, but it traps sweat against my skin and caused irritation.
I've got a plastic bag, and we use it for disposing of waste.
Each person needs their own specific fine-tuning in relation to positioning.
Delane had me lay all this out. Most of it we already use when he's up on the commode.
I think you're going to find that a lot of what you already know about performing bowel care up on the commode chair is quite similar to the techniques used in the sideline program. You'll still need the gloves, his stimulant medication, the toilet paper, the washcloths, and so on. In fact, now that we have Delane padded, I bet you know what to do next.
I bet I do. I wash my hands, put on a pair of gloves, because it's time to go to work.
It's nice that Darren's so conscientious about hand washing.
Thank you, Darren. I appreciate how well you keep things clean.
Oh, yeah. Stool contamination can cause urinary tract infections, food contaminations, wound infections. I can't ramble on. Since the rectal exam and applying the stimulant come back to back, I recommend laying out the stimulant and the lubricant at the same time. That way you don't have to go back and change gloves. I always make sure that a waste bag is open. Okay, now he's positioned and you're set up. What would you do now normally if he was up on the commode chair?
I'll start a rectal exam by thoroughly lubricating my index finger. Like so. Are you ready, Delane?
I guess I am. It's different, though, not being able to see what you're doing. Do you have plenty of lubricant?
Yeah, that's one thing I do, is use plenty of lubricant.
A water-based lubricant is different than a petroleum-based lubricant like Vaseline. Don't use a petroleum-based lubricant. They can produce a barrier that can prevent the stimulant from acting on the rectal lining of the bowel.
So how do you do a rectal exam, Darren?
Well, first, what I do is I gently insert my finger into his rectum, and I gently feel around to see if there's any stool. If there's stool, I gently begin to pull it out. We want to make sure that the mini enema has room to work.
I see you using one finger. One finger is the preferred method for the exam and for manual evacuations. There are occasions, though, when you might use two fingers, like if the stool were really soft and mushy, or if the stool is really hard and you just can't manipulate it out with one finger. It's common sense that the more fingers you use, the more manipulation and the greater risk of injury.
However, I didn't find any sphincter spasm in his anus, but I'm usually able to help him by putting pressure into his anus and helping the sphincter to relax. But when that doesn't happen, I just wait for it to pass.
Even though I can't feel it, I've taught Darren to be gentle, so it doesn't irritate my hemorrhoids and cause bleeding.
Another important reason for being gentle during the rectal exam is that the examining finger can trigger peristalsis. Over manipulation of the bowel lining when performing an exam or removing stool can cause peristalsis to start too early. Stool starts to come down, pushing out the stimulant, and thereby causing it to be less effective. Later on, your client can have an accident because of this.
And we don't want to have an accident.
Use of stimulant medication varies from person to person. There are many varieties of stimulants. Suppositories, mini enemas, and small enemas are commonly used. Many persons with spinal cord injury don't even need stimulants. Digital stimulation is all their bowel needs to trigger a full evacuation. A few people only need part of a suppository or part of the contents of a mini enema. Too much stimulant can trigger the bowel even after the process is complete. This leads to runny accidents later. Your client is the boss and will tell you whether to use medication and how much. Each spinal cord injured person will have their own individual response and preference in medications. If your client uses a stimulant medication, now is the time to use it.
Delane, you did say you use a mini enema, is that correct?
That's right, I use a mini enema. I've tried other stimulants, but this one works the best for me.
I cut off the very tip, making sure I leave a blunt end. Then I lubricate the tip and gently push neck end of the enema inside. The bulb gets slippery, so I have to hold on. Then I squeeze the bulb and hold it in place for about 5 to 10 seconds. By waiting for about 5 to 10 seconds before I remove it, it helps to keep the liquid stimulant inside and prevent it from flowing back out when I remove the bulb.
To apply a suppository, do a rectal check and make sure the rectum is empty of stool. It's important for persons with spinal cord injury to have their rectal vault emptied first. Inserting a suppository when there's still stool in the rectal vault can work for people with full sensation who are simply constipated, but it's not as effective for people with spinal cord injury. After you've checked for stool, gently push the well-lubricated suppository inside the rectum with your finger. Place it up against the bowel wall. Small enemas work pretty much the same as mini enemas, except they come with a slide-off cap and the neck is pre-lubricated. Insert it up to the base of the neck and squeeze.
Since this is going to take some time, I use the opportunity to catch up on my email and do my correspondence.
The actual amount of time required for bowel care varies from person to person. There are several things that may affect that amount of time. If the results were small the previous time, if you've changed your medication, if you changed the routine, or you didn't follow the routine, if you didn't eat right or do your normal fluids, those are some of the things. Your client will tell you how long it usually takes for him or her.
I used to have an attendant who would start stimulation before the medication had a chance to work. Well, he doesn't work for me anymore. I had an accident because we hurried. Be sure to wait until things start working.
Because we don't want to have an accident. Always wash up again with antibacterial soap. Be sure to include your forearms, because it's very easy to bump up against something that's already been contaminated.
Since Delane needs some time for the stimulant to work, I'll just clean him up, make sure he's okay, and then I'll go find something else to do in the house. I was taught a special technique on removing gloves with stool on them. First, you grab the outer edge of the dirty glove and you fold them in. Then you take that glove and put them in the clean glove and remove that clean glove and dispose of them. This way you keep everything clean.
Don't rush the waiting period. If you start doing digital stimulation before the stimulant has had a chance to coat the bowel lining, you won't get the full effect of the stimulant. Then bowel care takes longer to do, and the results may be small. This could lead to accidents later.
We don't want to have an accident.
Signs a stimulant are starting to work is a passing of gas and oftentimes a passing of stool. Some people wait for the passing of stool every time. This may work, but often lengthens the time spent on bowel care. If 15 or 20 minutes have passed and there has been no gas or stool passed, you can generally feel pretty confident that the stimulant has had enough time to work. Go ahead and start digital stimulation.
I can hear I'm passing gas now. Now's the time to start my digital stimulations. These stimulations help induce peristalsis. Darren will give me 2, maybe 3 simulations, as many as I need until my program is well on its way. Hey Darren, we need to lose the laptop before we start the dig.
It's not unusual for you to see stool start to pass before the stimulations, but that doesn't mean you can skip or stop the digitals.
Thanks Darren, that's right. I usually need digitals 2 or 3 times before I'm done.
Digital stimulations need to be repeated every 5 to 15 minutes. It's okay to find something else to do in the meantime, but be sure to wash up in between each sequence. Darren, can you show me how you do a digital stimulation?
I slide my lubricated finger past the anus and move my finger in a funnel-shaped motion, gently stretching the rectum. I do this for about 30 or 40 seconds. There may be some passing of gas and more stool may come down as I do this. I'll just make sure I clean up each time.
Some people with spinal cord injury may experience symptoms of autonomic dysreflexia with digital stimulation. These symptoms...
Whoa! Time out. Autonomic dysreflexia? That's a huge subject. It's serious stuff. It could be life-threatening. If your client is someone who's susceptible, you need to learn more about it. Now, let's move on.
Something you should pay attention to during bowel care is the consistency of the stools. And then let your client know. This will give your client a good indication of how the rest of the bowel program is coming along.
I don't want to be constipated or bordering on diarrhea, that's for sure.
There are a number of ways to tell if your stools are too hard or too soft. If it comes out formed and long, such as a cigar, or it may come out in little round balls. If the balls are fairly hard, it could indicate constipation. But if the balls are easily compressed, such as Play-Doh, then that's okay. The stools are fine. If the stool comes out kind of mushy and in a pile, that may indicate that the stools are too soft.
Delane's stool is a little soft. Here's some stool that is too hard.
I may need to adjust how much fiber powder I take or make changes in what I'm eating if my stool is either too soft or it's too hard. I use prunes before going to bed to soften my stool, and I increase my dairy product intake like cheese if I need to firm it up. I may need to avoid spicy foods, or I may need just to drink a little more water, depending on what it's like. But I can't know what changes I need to make if I don't know what the consistency of my stool is.
I kind of think of this as the Goldilocks theories. Remember when Goldilocks was going through the Three Bears' home? Papa Bear's chair was just too hard. Mama Bear's chair was too soft. But Baby Bear's chair was just right.
Penalty, flagrant violation for contaminating a cherished childhood story.
Digital stimulation continues to trigger the peristalsis in the colon to help the bowel empty out. Some people count how many revolutions they do. Some do as few as 3, others as many as 15. Just make sure that you maintain contact with the rectal lining with each revolution. Don't go beyond 1 minute. There's an area about 2.5 to 4 inches at the top of the rectal vault that feels like another anus. It's where the internal sphincter and some of the rectal muscles meet. By gently applying pressure with the fingertip, you can slide your fingertip in and give this part of the bowel a small digital stimulation also. There can be a lot of stool buildup between bowel care events, so it's so important to get out as much stool as possible each time.
If you place a stack of pads here next to Delane's bottom, you can take the soiled ones off the top as they get used. You could use some toilet paper on top, so then you could easily dispose of the stool in the toilet afterwards. Stool shouldn't be included in the garbage if you can help it. It can cause numerous public health hazards. I placed a plastic bag here to your right near his legs, so you can get to it quickly and easily.
If I notice any blood during bowel care, I make sure I do as little gentle digital stimulations as I can.
I would consider a small amount of blood to be if I could see it on my gloved finger. I know it's blood, but my finger isn't coated with it. Or if I see little streaks of red blood on the stool itself. Your client may ask you to wad up or roll up some toilet paper and hold it against the anus, such as a pressure dressing. If I begin to see more and more blood, if the bleeding doesn't seem to quit, or if the bleeding comes continuously or repeatedly, your client may be well advised to call his or her physician. There are a few signs that can help you tell when bowel care is over. Gas and stool flow have stopped. There may be a tightening of the rectal vault and inner sphincter. You may see a small amount of clear mucus follow the last stool. If there are no stool results after the last 2 digital stimulations, you can be pretty confident the bowel movement is over. Also, the client may have some sensation that it's done and be able to tell you.
I can usually tell when Delane is getting close to the end of his bowel care. When I do a digital stimulation and pull on my finger, all I see is lubricant.
Good communication with Darren and I is really important. I can feel the pressure release, and with Darren's help, I know when the mucus passes. That's a sure sign.
I can also tell by inspecting the rectal vault during my digital stimulation. I slide my finger through the anus. It kind of hugs my finger. There's an area that feels like it's open, and that area is the rectal vault. Then I slide my finger up the rectal wall. At what feels like at the top of the rectal vault is an area where some of the rectal muscles meet. If there's some stool present, it may be passing through this area, or it may feel like it's open. If I can't feel any stool and the rectal vault feels tighter, I'm pretty sure Delane is done. When we're done, I clean up around the area, making sure I seal that bag extremely well. I don't want to make work for anyone. Then I usually bathe Delane. It makes more sense for us to schedule it after bowel care rather than before or even at a different time of day.
Be sure that you thoroughly clean up and disinfect any area that may have been contaminated with the feces.
2-minute warning, the game is almost over. Time for a fast review.
Remember, there are 8 steps to bowel care. Position the client. Thoroughly wash your hands before and after each step. Examine the rectum for the presence of stool and remove any that's present. Apply a stimulant if a stimulant is used. Wait for the stimulant to act. Do digital stimulations of the rectum. Recognize when the bowel is empty and the need for the bowel care has ended. Then thoroughly clean up when you're done. And don't rush it because
we don't want to have an accident.
Bowel care? Well, really, that's not something we talk about in polite society.
Polite? I don't think so. But we do need to talk about these things.
The memories of my first bowel care date all the way back to ICU.
They started bowel care immediately after my injury. I felt like I was being violated.
Remember, everybody's embarrassed about bowel care.
When I first heard about it, I thought, what? Help him with a bowel movement? How?
Especially attendants when they begin. One of my hardest problems at first was to be nude in front of a female attendant.
Bowel care is not a sexual thing.
Bowel care is staying ahead of the game. It'll prevent accidents.
Got to get all that stool out. There's nothing worse than unfinished business.
The job is gross, and at times the smell is real bad.
Bowel care is a hassle, but it's better than having an accident.
Everything that I get out with manual evacuation or digital stimulation is an accident I won't have to clean up. If you don't get it out, it'll come out and get you.
And I knew I had a little bowel accident. Of course the smell was there also, and I looked around and there was a baby and there was a dog on the bus, so I was hoping that people were going to interpret the smell from the baby and the dog. And on the return trip I didn't take the bus, I just took the chair, went home, so I didn't have to worry about upsetting people's noses and senses.
I had a pair of pants that were Jinx. Every time I wore them, I would have an accident, so I got rid of them.
I teach my attendant the proper terms when it comes to a bowel program, like the colon, and the anus, and the sphincter, what's involved in the bowel movement, and proper bowel care.
Well, those terms are real good for a lot of folks, but we tend to be a little bit more relaxed. We tend to use a little brown eye for the anus and a dig for a digital. And she tends to leave me presents, and we call them little log cabins.
A little bit of joking along the line helps everything move on through.
In the beginning, I was very embarrassed to ask Joni for digitals, and I paid with a lot of accidents.
My first reaction to digitals, you gotta stick your finger where?
I used to be very afraid of giving her digitals for fear I would hurt her. But then I found out that bleeding happens occasionally.
When I finally asked, I found out that she was very willing to do digitals.
Understanding what a digital does makes it easier to ask for.
When it's time for a digital, I ask him if he would like a digital. That way it keeps the whole process under his control.
That's right, I'm the boss.
Because we know